Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. Today, we turn our attention to a milestone in the overdose crisis. Recent news that the overdose death rate of Black Americans is soaring and has passed the overdose death rate of white Americans. Dr. Josh Sharfstein speaks to Dr. Keisha Solomon and Dr. Jason Gibbons, two postdoctoral fellows at the Johns Hopkins Bloomberg School of Public Health who are focusing on this trend. Let's listen.
Keisha Solomon, Jason Gibbons, thanks so much for joining me to talk about this urgent topic, the increase in overdoses among Black Americans. Keisha, what did the data show?
Thank you for having us. The data show that the overdose death rate among Black Americans surpassed that of white Americans in 2020. This is a sharp reversal of the situation a decade earlier, when rates were twice as high for white Americans than Black Americans. For example, between 2013 and 2020, there was a five-fold increase in the rate of Black Americans dying from opioids compared to a two-fold increase among white Americans. This is particularly concerning given the overall rate of opioid misuse between Black and white Americans has been similar during this period. It's about 4% in each population. In total, 15,549 Black Americans died of overdoses in 2020.
So the actual use of opioids is about the same between Black and white Americans, but there's been a much faster increase in overdose deaths among Black Americans in the last decade. This is a trend that begs an explanation. What's going on, Jason?
So we think one contributing factor could be the drug supply. We've observed significant increases in the supply of fentanyl over the last 5 years in areas of the country where there are large populations of Black Americans residing. For context, fentanyl is an opioid that can be extremely unpredictable in its potency, making it more likely to cause an overdose. And interestingly, it caused virtually no overdoses a few years ago, but now accounts for roughly 73% of all overdose deaths. Unfortunately, in many cases, people who use drugs are unaware that they're consuming or exposed to fentanyl and accidentally take a lethal dose. This is particularly true among people using stimulants like cocaine and methamphetamines. Moreover, although rising fatal and non-fatal overdoses among Black Americans have been observed across the entire country, we're seeing particularly concerning rises in overdose rates in Northeast and metropolitan locations. These locations often have a lot of fentanyl in the drug supply, explaining their relative impact. Major cities such as New York, DC, and Baltimore have experienced some of the most concerning increases, especially among Black American men aged between 40 to 60.
So one possible explanation could be changes to the drug supply that are particularly dangerous to Black communities. What about their access to programs and services that can reduce the risk of overdose? Keisha?
Thanks, Josh. Yes, that is a big issue too. There are life-saving treatments and services, but Black Americans consistently have less access to them and as well as use them less. In the setting of fentanyl and rising overdoses, this lack of access costs lives.
Can you give me some specific examples?
Sure, I can give you about 5 examples. First, let's start with insurance coverage. Black Americans are twice as likely to have Medicaid as white Americans. Yet substance use disorder treatment facilities that accept Medicaid are less common in communities with high proportions of Black Americans. Second, there is inadequate follow-up care after non-fatal overdoses. Specifically, among patients who experience non-fatal overdoses, Black patients are half as likely as white patients to obtain follow-up appointments for opioid addiction care after leaving the emergency department. Third, there are provider shortages in Black communities. Specifically, studies have shown that prescribers of buprenorphine, the gold standard opioid use disorder treatment, are more likely to operate in predominantly white communities and are less likely to take Medicaid than commercial insurance or self-pay. Fourth, there are biases within the medical community that affect access to and use of treatment. In particular, many studies have suggested that interpersonal discrimination from providers has reduced the use of substance use disorder treatment services by Black Americans seeking treatment. And another example is that there are transportation and housing disparities. And transportation and housing stability is essential to obtaining and maintaining substance use disorder treatment, but Black Americans with substance use disorder are less likely to have stable housing and transportation relative to white Americans with substance use disorder.
So the picture is getting clearer. It may be both because of changes to the drug supply, as well as less access to life-saving treatment, that we're seeing this sharp rise among Black Americans in overdose, and in fact, now passing white Americans for the first time in a long time. I wonder whether we're seeing a disparity in access for harm reduction services for people who may not be ready for treatment, but may still benefit and may still stay alive if they're connected to these kinds of programs.
Yes, unfortunately, it is present there too. In particular, Black Americans are less likely to use and have access to harm reduction services, especially naloxone, which can reverse opioid overdose. Further research has shown that there is inadequate supply of harm reduction providers in Black communities, which may be contributing to disparities in the use of these services. Harm reduction service use differences may also be explained by more significant fears of incarceration for possession of drugs among Black Americans due to structural racism in the criminal justice system. And this has relevance to fentanyl, which Jason mentioned earlier. One form of harm reduction is fentanyl test strips, which can help people identify the presence of dangerous fentanyl before using drugs.
So we have a more dangerous drug supply, less access to treatment, less access to harm reduction. Are there any other recent factors that could be contributing to this shocking increase in overdoses in the Black community?
Yes, we know that the COVID-19 pandemic has affected Black communities especially hard. Specifically, Black Americans have been overly represented in COVID-19 infections and fatalities. Further, the economic dislocation and mental health trauma of the pandemic may be driving some of this extraordinary increase in overdoses that we are observing.
Thank you. I think we've gotten into what's happening and a little bit into why. I want to turn to potential solutions. Where do we start, Jason?
Recognizing the problem is honestly the first step towards addressing it. The opioid epidemic is not just a problem for white communities, it's a problem of racial equity. The public and policy conversation needs to recognize this alarming trend. Everyone working in this area has to be paying attention to the rising overdose rate and respond in kind. This is particularly true when it comes to the allocation of funds, resources, and the establishment of policy and treatment programs. The new opioid litigation settlement funds have actually created a unique opportunity to invest more heavily in Black communities hardest hit by the recent wave of the epidemic, and states should really work to develop equity transformation plans to ensure that these funds actually reach Black communities.
Thank you. Keisha, what does that mean at the community level? What should be done differently?
Communities can start by listening to the experiences of Black Americans who use drugs to understand the core issues that they face in their communities. Further, ignoring history and context breeds mistrust and a sense of devaluing the community. Next, there is a growing body of evidence that suggests that Black Americans have very different experiences interacting with the healthcare system than white Americans, especially in the context of substance use disorder treatment. In particular, Black Americans have often described being treated as less trustworthy and referred to as addicts, while white Americans are more likely to be treated as patients with an illness they have no control over. To fix this, the healthcare industry should train providers to understand local community issues such as historical mistreatment and undertreatment in Black communities, and to provide empathic care to all. It also means hiring more staff and providers from communities they are caring for, increasing the access to peer-to-peer services and other social services through the formation of public-private partnerships with community organizations. And finally, the communities could mobilize churches and other faith-based organizations.
Jason, what about changing policies for addiction treatment? Is there anything there that could help?
So Congress can definitely take some steps to improve access to medication in many more communities. One idea that has already passed the House of Representatives is to end the requirement for an extra waiver before physicians can offer buprenorphine for drug treatment. In the same light, it's also possible to improve access to methadone. Who use drugs are disproportionately treated with methadone, which is regulated much more strictly than buprenorphine. In particular, patients treated with methadone are more likely to be subjected to extra drug testing and other burdensome requirements. They often must also travel daily to treatment programs to have medications administered and can be kicked out of programs when they aren't able to jump through the various hoops set up for them. More generally, it's time for the federal government to streamline these rules so that it's a lot easier to access methadone treatment, to stay in treatment, both of which have been shown to save lives.
Anything else to think about at the policy level, Keisha?
Yes, policy reform should also focus on addressing the routine incarceration of Black Americans with substance use disorders, who are disproportionately at risk of overdose. It is estimated that over 20% of individuals that fatally overdose are those recently released from incarceration, and Black Americans are disproportionately incarcerated due to structural racism in the criminal justice system. Therefore, the long history of incarcerating Black Americans for nonviolent drug offenses should end. Further, There should be policies that ensure recently incarcerated individuals have Medicaid coverage prior to their release and are also linked to care in the community.
That is a very important policy agenda. And I wonder whether there are also critical research questions that need to be explored to better understand what's going on and come up with new types of policy answers. I'll start with you, Keisha.
Yes, I think we need additional research to understand the cultural and structural factors that are affecting drug use and access to treatment among Black Americans. Specifically, we need local data to answer these questions because most current research projects use national data that do not capture cultural and structural factors.
Jason, other thoughts from you about research?
So we need to get better at measuring changes in the drug supply in local communities, especially fentanyl. Toxicology data can be used in conjunction with criminal justice data to identify communities that are at high risk of being exposed to fentanyl. Once identified, local government will be alerted to begin awareness campaigns and provide additional harm reduction services like naloxone kits and fentanyl test strips.
Thank you, Josh. Finally, I think that policy should respond to disparities in the social and economic conditions in Black communities, most heavily impacted by the opioid epidemic. Especially given that these conditions have worsened since the onset of the COVID-19 pandemic. Further, it's important to note that the increases that we are observing, the factors that are contributing to these increases are complex. However, there are solutions at every level. What's most important is that we cannot accept these rates of overdose as a new normal.
Great. Thank you. Thank you, Keisha Solomon, Jason Gibbons, for joining the podcast to talk about this incredible challenge today.
Thank you for having us.
Thanks so much for having us.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.